Okay, so on these patients, 1 week history of irritable mood, hyperactivity, distractibility, and impulsivity, decreased need for sleep, grandiosity, resulting in severe impairment, risky behavior at work resulting in probation, and a near serious injury suggest manic episode. The presence of the presence of a manic episodes makes bipolar 1 disorder the most likely diagnosis. The diagnosis of the hypomanic and manic episodes require elevated or irritable mood and increased energy plus three of the following: distractibility, impulsivity, grandiosity, flight of ideas or racing thoughts, activity, decreased need for sleep, and talkativeness. In hypomanic syndrome, in hypomania, symptoms are less severe and functioning is improved only when slightly impaired, unlike in this patient who is on probation and whose risky behavior have resulted in serious injury. If psychotic symptoms are present, the episode is manic by definition. If psychotic symptoms are present, the episode is manic by definition. Diagnosis of bipolar 1 D does Diagnosis of bipolar 1 disorder does not require a history of major depressive episode. Bipolar 2 is characterized by episodes of major depression and hypomania, not mania, as in this patient. Okay, yes. Okay, it's a brief psychotic disorder. The presence of one or more than one psychotic symptoms, delusion, hallucination, disorganized speech, grossly distorted behavior, catatonic behavior, lasting more than one day, less than 1 month, with full return to the normal functioning, is consistent with brief psychotic disorder, as in this case, in which the patient actually developed and bizarre behavior, paranoid delusion and bizarre behavior following life-threatening incident. Sympt- Symptoms of brief psychotic disorder often develop in reaction to a marked stressor. Diagnosis requires ruling out ruling out psychotic disorder due to substance or medical conditions or longitudinal assessment to confirm remission within a month. Brief psychotic disorder can be differentiated from other psychotic disorder by duration. In delusional disorder, more than one delusion must be present for more than 1 month. And in schizophrenic disorder, psychotic symptoms lasts more than 1 month, less than 6 months. These patient's symptoms resolve within a month. Okay, yes. I'm overthinking a lot. Okay, yes. I It's a MDD. Everything fits with MDD. Even if it fits MDD, I choose this time because yes, like he reports that he has been through tough year because so I thought that it is more than 2 years. Okay, okay. This patient's history of sad mood, loss of interest, fatigue, hypersomnia, and impaired concentration lasting more than 2 weeks is consistent with MDD. Although his depressive symptoms were likely triggered and exaggerated by bereavement and professional setbacks, they are persistent, severe, and functionally impairing. MDD is appropriate MDD is the appropriate diagnosis when symptoms are sufficient in number, duration, severity to meet the diagnostic criteria. This patient should be offered treatment of MDD consisting of a psychotherapy and antidepressant medication. Okay, persistent complex bereavement disorder, also referred to as complicated grief, is characterized by persistent yearning for the deceased, and prolonged emotional pain related to the loss, accompanied by maladaptive ruminative thought and dysfunctional behaviors. Next, pramipexole ropinirole dopamine agonist. Mm, yes, it may cause. Okay, you think by yourself. Okay, this elderly patient with no psychiatric history now has symptoms suggestive of mania, new onset behavioral change, in an older patient with no new onset behavioral changes in an older patient with no psychiatric history should prompt consideration of medical and substance medication related causes. This patient typically started taking ropinirole, a dopamine agonist medication used for restless leg syndrome that has high affinity for D2 and D3 receptor receptor. Treatment with um, treatment with dopamine agonist, even at therapeutic doses, increases the risk of impulse control disorder that may present with manic like signs and symptoms. In the absence of a history of impulse control problems, manic or depressive episodes, or medical condition known to cause mania, this patient is most likely experiencing a dopamine agonist, include impulse control disorder. Other impulse behaviors that may occur with dopamine agonist therapy include pathological gambling, compulsive shopping and eating, and hypersexuality. The first step is to discontinue the offending medication ropinirole and monitor the patient's mental status. Medication induced behavioral changes are usually medication induced Behavioral changes are usually reversible and resolved quickly once the medication is stopped. Yes. Okay, it's this patient preoccupation with somatic symptoms. Preoccupation with somatic symptoms despite negative workup is suggestive of somatic symptom disorder, a psychiatric disorder characterized by excessive anxiety and time-consuming behavior related to thoughts about the seriousness of one or more physical symptoms. Patients with somatic symptom disorder frequently and extensively use medical services and request additional testing because normal results are rarely reassuring. Patients with this condition typically seek care from multiple providers. In addition, in initial management of somatic symptom disorder consists of arranging regularly scheduled visits with the same physician to develop physician-patient relationship and minimize unnecessary testing, interventions, and subspecialty referrals. Routinely scheduled visits that are not symptom driven do not require patients to develop worsening or new symptoms. Okay. We can give atypical antipsychotic, isn't it? Yes. Like a close up in is if nothing can works, then close up in. If patient is on two antipsychotic, like two antipsychotic fails, then we will give close up in, isn't it? It worked, yes. Yes, close up in. I close up in for two failure or treatment resistance schizophrenia. But there is a problem. He is discontinued for muscle spasm in the neck and this and that. So he has some sort of syndrome like acute antipsychotic, like extrapyramidal syndrome. Yes, yes. It's I think it's second generation. Okay. So this patient acutely psychotic and requires prompt treatment with antipsychotic medication. Although he responded to haloperidol during his previous episode, he experienced major tolerability issues due to extrapyramidal side effects. PPS are more common with high potency first generation antipsychotic, such as haloperidol due to their potent dopamine D2 receptor antagonism in the nigrostriatal pathway. Approach the best approach in this patient would be treat with second generation antipsychotic. Aziprasidone, it reduces the extrapyramidal side effect. Among the second generation antipsychotic, ziprasidone has low metabolic risk profile, whereas olanzapine has the highest weight gain and metabolic side effect, insulin resistance, hyperlipidemia, and should be avoided in this patient due to history of type 2 diabetes mellitus. Other second generation antipsychotic with lower metabolic risk include aripiprazole and lurasidone. So these can be used. So we can give olanzapine, but we are avoiding it because of its major side effect. Like okay, so okay, I haven't seen that. Is it RLS or rapid eye movement disorder? Okay, sorry. Okay, yes. I was distracted like uh, slight slowness of gait. Like RLS has one risk factor like Parkinson. M- Maybe RLS has a risk factor like iron deficiency anemia. Isn't it there another risk factor like I as far I remember is Parkinson disease is the risk factor of RLS? May not be. Okay. Mm, okay. Yeah. No. No. Parkinson disease. Look at this box. Parkinson. Okay. In RLS, one of the risk factor is Parkinson disease. Yes. Look here. I have shared the screen. Iron deficiency anemia is the must, but the Parkinson and multiple sclerosis and DM are the other risk factors too. Okay. 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 So you can share screen. Okay. Our rapid eye movement, sleep behavior disorder. Rapid eye movement, sleep behavior disorder is characterized by that occur during complex motor behavior that occurs during REM sleep. Normal REM sleep is characterized by muscle atonia. However, in rapid eye movement sleep behavior disorder, there is a degeneration of the brainstem nuclei responsible for inhibiting spinal motor neurons during normal REM sleep leads to incomplete or absent muscle atonia, facilitating dream enactment behavior. These behaviors are most likely due to these behaviors are more likely due to during the later half of the night when the relative percentage of REM sleep is higher. Patient can usually be awakened fairly easily are and are alert or oriented. They may not recall their movements during sleep, but can often recall their dreams. Rapid eye move, RBD is most likely RBD is most likely to occur in older adult women. If frequent and recurrent, it may be prodromal signs of neurodegeneration with risk of subsequent onset of Parkinson's disease or dementia with Lewy bodies. RBD is frequently accompanied by prodromal signs and symptoms of neurodegeneration such as subtle motor deficits, slowed gait, anosmia or constipation. Narcolepsy and antidepressant medication initiation are also associated with RBD. Okay. Yes, RLS involves overwhelming urge to move the legs, is commonly associated with sleep disturbance and involuntary jerking movements of the legs during sleep. It would not explain patient dream enactment with complex motor behavior. Okay, this patient has body dysmorphic disorder. Body dysmorphic disorder, preoccupation with one or more than one perceived physical defects not observable or appear slight to others, repetitive behavior performed in response to preoccupation, mirror checking, concealing, excessive grooming, and skin picking, significant distress or impairment, variable insight, good, poor, absent delusional belief, approach to patient acknowledgeable distress, do not refer to a perceived flaws as imagined, reassurance about normal appearance rarely helpful, focus on alleviating distress and functional impairment, avoid inappropriate cosmetic or medical or surgical treatment. Treatment is antidepressant, SSRI, and CBD. So these patients excessive preoccupation with a slightly or non-existing defect in physical appearance, believe that her nose is scarred from acne and is consistent with body dysmorphic disorder. In response to appearance concern, patients with BDD engage in time-consuming behavior such as this patient repeatedly examine her appearance in mirror and reapplying makeup to conceal her perceived defect. Patients with BDD typically have limited insight into their condition and therefore require a sensitive and tactful assessment approach. The physician should acknowledge their distress and avoid referring to perceived defects as imagined or arguing with them about their appearance. Physicians should empathize with patient efforts to cope with their condition and determine their level of insight by gently exploring their uh, perception of how others see them. In body dysmorphic disorder, insight can range from fair to good to poor to absent, or like patient thinks belief about appearance are probably definitely true or definitely true. Okay, next. Can I call you within a minute? I have a call. Yes. Yes.
on the station's website.
Okay. So it's histrionic personality disorder. So patient's intense need to the center. The patient's intense need to be the center of the attention, preoccupation with physical attractiveness, and dramatic emotional displays are consistent with the diagnosis of histrionic personality disorder. Patients with histrionic personality disorder become distress in situation where they are not the center of attention. Frequently use physical appearance, physical. Okay, I'm calling within a minute. Wait. Okay. হ্যালো, হ্যাঁ লিঙ্কন। হ্যাঁ বলো। কোনটা? কোনটা নেই? তাহলে জিজ্ঞেস করো নিম টয়েন আছে কিনা। নিম টয়েন কমপ্লিট। নিম টয়েন আছে, নিম টয়েন আছে। নাইট্রো ফুরেন্টাইন। তাহলে নাইট্রো ফুরেন্টাইন দিয়ে দেন 100 7 দিন। বুঝি নাই। তাহলে শুধু ওইটা থাকলে ওইটাই দেন, শুধু ফসফোমাইসিন দেন। ওইটা তো একটা দিলেই হবে। আপনি এই আর শুধুমাত্র ওইটাই দেন, ওই যে ফসফোমাইসিন যেটা আছে, ইউটিসিন যেটা আছে। হ্যাঁ, হ্যাঁ দেন ওইটাই দেন। ওইটা দিলেই হবে। ঠিক আছে। হ্যাঁ শুধু ওইটাই দিবেন। হ্যাঁ, আচ্ছা। হ্যালো, শোনো, যেটা দিতেছে এই যে ইউটিফল যেটা, ঠিক আছে, এটা হলো 3 গ্রাম। একটা ডোজ খাইলেই তোমার মানে যে 7 দিনের অ্যান্টিবায়োটিক খাওয়ার যে ওইটা একবারে কাভার হয়ে যাবে, বুঝছো? যাও বাসায় যাবা, এই 3 গ্রাম যে স্যাচেট আছে এটা পানির সাথে মিশিয়ে যেখানে লেখা আছে ওটা খাবার খাওয়ার পরে 7 দিন পরে তুমি আবার আরেকটা ইয়া করো মানে এই যে ইউরিন আর ইয়ে করো দেখো আশা করি ইনশাআল্লাহ করবে বুঝছো এটা হ্যাঁ হ্যাঁ যেটা জ্বালা পোড়া একটা চলবে জ্বালা পোড়া একটা 7 দিন আরো কন্টিনিউ করবে আর এই যে ওষুধ যেটা দিতেছি এটা একটা খাইলেই এক স্যাচেট খাইলেই মোটামুটি মনে করো 7 দিনের অ্যান্টিবায়োটিক খাবার হ্যাঁ পাউডার পানির সাথে মিশিয়ে দিতে লেখা আছে এখানে দেখো কিভাবে কিভাবে করতে হয় ঠিক আছে এটা খাও এটা ভালো এটা নতুন ঠিক আছে আচ্ছা হ্যাঁ এক ডোজেই পুরো সব কমপ্লিট পানি যেরকম খাও ওরকমই খাবা পানিতে ডিহাইড্রেশন হলে যে কোনো সময় ইউটিআই তো হবে তোমার তো ইনফেকশন তো আছে আসছেন তো আছে পানি খাইতে হবে পানি বেশি খাইতে হবে আর ওই যে তুমি তুমি পানি রাখবা তুমি সবসময় বোতল ক্যারি করবা তোমার উচিত হইলো বাইরের থেকে মিনারেল ওয়াটার না ইয়া করে বাসা থেকে বোতল ক্যারি করবা বোতলে থাকবা বোতল রাখবা আর হিসাব থাকবে ঠিক আছে যে দিনে কয় বোতল খাইছি এমনি একটু 2 সিপ এই সিপ খাইলে এগুলা পানি খাওয়া হয় বুঝছো গরমে তুমি এই পানি মিনিমাম তোমার জন্য মিনিমাম 2.5 থেকে 3 লিটার পানি খাইতে হবে ঠিক আছে 2.5 থেকে 3 বোতল রাখো বোতল রাখলে হিসাব থাকে ঠিক আছে hello yes okay okay I'm reading the explanation so it's histrionic personality disorder in histrionic personality disorder clinical features pattern of excessive emotionally and attention seeking behavior since early adulthood inappropriate sexually seductive or provocative behavior uses appearance to draw attention shallow shifting dramatic emotions uh, impressionistic vague speech suggestible early influenced and consider relationship more intimate than that than they really are. These patients' intense need to be the center of the these patients' intense need to be the center of the attention, preoccupation with physical attractiveness, and dramatic emotional displays are consistent with the diagnosis of histrionic personality disorder. Patients with histrionic personality disorder become distressed in situations where they are not the center of the attention frequently use physical appearance to attract attention and often behave in a sexually seductive or provocative manner. They have an overly dramatic communication style like crossing arms dramatically, exaggerated facial expression, and hand gesture with rapidly shifting emotions, easily becoming extremely upset, bursting into tears, and impressionistic speech. Real friends don't stab you in the back like that. They also frequently perceive personal relationship to be more intimate than they may be in reality. I thought he was my friend. As with all personality disorder, a diagnosis of histrionic personality disorder requires that the patient demonstrate a persistent pattern of problematic behavior since early adulthood across many contexts. The differential diagnoses include other personality disorders, mood disorders, and other psychiatric disorders that may present with intense or excessive emotions. All the patients with narcissistic personality disorder (NPD) also need to be the center of the attention. They typically do not exhibit the dramatic emotional display seen in this patient. So this point is important. Difference between the narcissistic and the uh,
Histrionic.
histrionic. Okay. Okay, next.
57-year-old woman was diagnosed with intelligent short-term memory disorder. Clinical symptoms include persistent anxiety, symptoms are not unusual for ADHD patients. Yes, anxiety.
Okay, it's generalized anxiety disorder. So these patients' pain, insomnia, fatigue, poor concentration are consistent with generalized anxiety disorder. Although excessive worry and multiple issues is the key symptoms of the GAD, patients frequently come to primary care with somatic symptoms include fatigue, physical symptoms are related to the muscle tension, fatigue, muscle tension, and headache, neck, shoulder, and back pain. Other physical manifestation of anxiety commonly seen in GAD, trembling, sweating, and GI symptoms. GAD is a lifelong chronic course with symptom severity increasing during periods of stress. As in this patient, GAD is effectively treated with serotonergic antidepressant, mm, cognitive behavioral therapy, or a combination of the two. Okay.
Yes. My 8-year-old noticed that her husband, who is concerned about his recent behavior, showed persistent anxiety and depressions. He did anything that is not too adverse to the relationship. The reason I asked the question is because in the past,
Is it
I don't know. The thing is,
delusional and paranoid?
it's definitely not paranoid. Um,
You are
it's not. I think it's paranoid
why it's not paranoid?
because maybe around so what happens how do I put it?
And for being delusional disorder, you need to like more than 1 day or less than 3 months, isn't it? A false belief. Oh, yes. Obsessed with the food, Ob- with 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 his symptoms, maybe. Okay, I was confused in between delusion and paranoid. I have said so. Pa- yes, I was confused about the paranoid one. Okay, okay, no problem. Okay, more than one delusion for more than 1 month and other psychotic symptoms absent or not prominent and behavior not obviously odd or bizarre and ability to function apart from delusional impact and subtype erotomanic, grandiose, jealous, persecutory and somatic. Treatment is antipsychotic and CBT for delusion antipsychotic. Okay. Okay, this patient's persistent delusion about being poisoned in the absence of prominent psychotic symptoms, in the absence of other prominent psychotic symptoms, is consistent with delusional disorder. Her behavior, unrelated to her delusion, does not appear to be bizarre or odd, and she is still able to function at work. Delusional disorder may be subtyped based on delusional themes: persecutory, erotomanic. Persecutory is being poisoned, harassed, and plotted against. Erotomanic is false belief that someone of higher status is in love with them. Grandiose is great talent, insight, achievements. Jealous is unfaithful or partner. Somatic, bodily function, sensation. Delusional disorder must be differentiated from the psychotic disorder. Patients with schizophrenia have additional psychotic symptoms: hallucination, disorganization, negative symptoms, and greater functional disorientation. Okay, yes. Patients with uh, illness, anxiety appearance, illness, anxiety disorder experience anxiety with excessive concern and preoccupation about having a serious medical illness, but they do not have delusion. If anxiety about being ill is related to a fixed delusional belief, poisoned food, then delusional disorder is appropriate diagnosis. Option C, the patient lacks of intrusive obsession and time-consuming compulsive rituals required for the diagnosis of OCD. Personality disorder are characterized by lifelong patterns of behavior beginning in the early adulthood. They do not involve delusional belief. Paranoid personality disorders involves pervasive distrust and suspicious of others. Patients with schizotypal personality disorder exhibit eccentric behavior which may include suspicious or odd belief, but their beliefs are not delusional intensity. This patient has developed delusions over the past 6 months, which represents a change from her baseline. Okay.
with everyone. During a recent study, the person accused the contact of having discussion on computing. He had experienced strange behavior. One student reported shaking in his hand and turning white and dark. Patients say that functional difficulties and issues from communication like verbal cognitive design stress somewhat suicidal cooking was fun until they said it wasn't anymore.
Okay. So this patient's history of mood swings and erratic behavior and a history of findings consistent with sympathetic nervous system stimulation, tachycardia, pupil dilation, diaphoresis tremor are most likely cocaine use disorder. Psychiatric effects of cocaine include irritability. Can you hear me?
Yeah.
Okay. Um, Cocaine include anxiety, irritability, mood swings, panic attack, grandiosity, impaired judgment, and psychotic symptoms, paranoia, hallucination. When intoxicated, patients using cocaine are frequently energetic, restless, and hypervigilant, and may exhibit euphoria and grandiosity that resembles an acute manic episodes. Paranoid and grandiose delusion are auditory, visual, and tactile hallucination may occur. Cocaine withdrawal frequently presents with depression. Cocaine withdrawal frequently presents with depression and lethargy, which resolve spontaneously after a period of abstinence. Yes, a diagnosis of the bipolar disorder requires distinguishable episodes of hypomania, mania, and a depression lasting for a determined period for more than 4 days for hypomania, and more than 1 week for mania, for more than 2 weeks of major depressive episodes rather than mood lability lasting a few days at a time, as seen in this case. Diagnostic criteria for cyclothymic disorder include at least 2 years of alternating hypomanic and depressive symptoms not meeting full criteria for hypomanic or depressive episodes. However, evidence of mood symptoms in bipolar and cyclothymic disorder must occur independently of substance use. In addition, this patient has abnormal vital signs, dilated pupil, diaphoresis, tremors, which are not symptoms of a primary mood disorder and are better experienced by sympathomimetic drug use.
So no significant disorders within psychosis or diagnosis.
Is it panic,
It sounds like
heart pounding, shortness of breath, chest pain, shaking, tingling?
the feeling of vulnerability and dysfunction all the time. Okay, I guess
And you were talking about depersonalization and derealization, that I am not me, not me.
yeah,
Yes. And it's not generalized anxiety disorder also. Yes. No, 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 not like that. In illness anxiety, patient has the what can I say? Excessive anxiety about something bad is coming, but not this kind of serious symptoms. Like he has some sort of symptoms like chest pain, irritable, fatigue, shortness of breath. This does not come with illness anxiety. No, he is not faking. Okay, there we have found more than four feature like chest pain, one, palpitation, shortness of breath, like he has depersonalization, derealization, like in the middle where we are very confused about depersonalization and derealization. So it is one of the feature of panic disorder. So all fits with the panic. Okay, the unexpected and abrupt onset of symptoms in the otherwise healthy patient with repetitive a healthy patient with repeated negative medical workups is suggestive of panic disorder. Patients with panic disorder frequently have cardiorespiratory symptoms. Patients with patients with panic disorder frequently have cardiorespiratory symptoms. May have fear. May fear that they have a heart attack and repeatedly seek medical care, and other symptoms include gastrointestinal distress, anticipatory anxiety, and dissociative symptoms, depersonalization, derealization. Patient typically develop anticipatory anxiety about subsequent attacks, may develop chronic anxiety. These patients okay, they may reasonably become preoccupied with their symptoms and fears of having undiagnosed condition, making it difficult to differentiate panic from other somatic disorders. Okay.
Would you like to respond of the question or you want to answer?
MDD with psychosis,
What?
like sertraline and risperidone. Escitalopram and bupropion. Okay, we can give bupropion because he has massive weight loss. But what we will do for weight loss? You are with Escitalopram is like SSRI, and bupropion it cannot be used for psychosis. I am worried about his weight. Okay, maybe maybe you are right. Yes. So it's MDD with psychosis. I am thinking over. I got 1% right. Okay. And these patients are worsening depression. These patients worsening depression, development of delusion, consistent with MDD with psychotic feature. MDD with psychotic feature are severe subtype of depression characterized by delusion and hallucination. Psychotic features typically have depressive themes such as guilt, worthlessness, and dying. This patient delusion that her body is decaying and she deserves to die. Accurate diagnosis is important because treatment of MDD with psychotic feature differ from the treatment of non-psychotic depression, antidepressant monotherapy. First line depression, antidepressant plus antipsychotic, SSRI, like sertraline and risperidone. ECT is another first line option, but it is typically reserved for patients who require rapid response due to severe suicidality. or refusal to eat or drink. ECT is a good option for psychiatry, but in the movies, wha- what we have seen, like people are not gonna accept this.
Yeah, I very much agree.
What is your diagnosis?
Completely fine.
Where is mania? Uh, She repeatedly refers herself as a cat burglar. She laughs loudly, experiencing sensation of bugs crawling into the skin, or experience intrusive unwanted thought. Okay, feeling a sense of detachment of self of the environment. It is depersonalization type of thing. Panic attack, yes. And feeling well rested despite minimal sleep. Mania, yes. Neglect, personal grooming. What does it mean? Yes, and yes, pausing for long periods prior to responding the question. Yes, you are in the mania. You think it's manic, maybe manic. I am finding the word where manic is. Stay with your answer. Which, yes, I don't know how they fix it manic. I am not finding the any manic part. Okay, I'm reading the explanation because the above part is unnecessary actually. Okay, these patients' recent history of abnormal mood, impulsive, risky behavior, and grandiosity believe that only she, okay, believe that she can save the animals, as well as a loud speech, distractibility, and inappropriate joking and laughter on the mental status examination. Okay, these are the manic. Okay, inappropriate joking, laughter on mental status examination are characteristics of manic episode of bipolar disorder. Mania, Patients with mania are often expansive and disinhibited, interacting with strangers without regard to social conventions, yelling at others walking by. Impaired judgment is common as well. Impaired judgment is common as with this patient abruptly quitting her job, trespassing at the animal shelter. A key feature of mania is decreased need for sleep due to increased energy. This is differentiated from insomnia, which refers to difficulty sleeping despite feeling tired. Difficulty sleeping despite feeling tired. Patients with manic episode may sleep only a few hours or go without sleep entirely for several days. Despite lack of sleep, they feel rested and energetic. Mania typically has acute onset, rapid progression, often a few days, resulting in marked impairment in functioning. Hospitalization may be necessary to protect the patient from further destructive behaviors. Next.
So history by the sense normally physical data are diagnosis.
Okay. Generalized anxiety.
Yeah.
Okay.
I mean, not COVID.
Initially, okay. Initially, I start with the somatic symptom one.
That's why I asked you that.
Yes, because evaluation of the muscle tightness, he reports stiffness. These are the somatic symptoms, and he starts a new job. And the lazy people like me, when he starts a new job, he gets this type of somatic symptom. Okay, you don't know how drowsy I am.
Oh,
Okay, so I have some problems. Okay, so this patient 6 month history of feeling overwhelmed by anxious thought, accompanied by symptoms or muscle tension, irritability, impaired concentration, fatigue, is consistent with generalized anxiety disorder. Patients with GAD experience chronic or pervasive anxiety, worry excessively about everyday matters. They often describe lifelong anxiety, but experience worsening symptoms during periods and increased stress, as in this patient after starting a new job. Symptoms of GAD may Also include feeling restless on the edge, sleep disturbance characterized by difficulty falling or staying asleep. Okay, okay, we can take a break, then we can start. Okay.